For decades, interstitial lung disease was defined by a steady, irreversible decline. Today, the focus of clinical research is moving toward a different objective, the anatomical lung regeneration of the parenchyma itself. To understand how this transition is possible, we have to look at where the damage starts, the alveolar capillary interface. In a healthy lung, this ultra-thin barrier acts as a gate, allowing oxygen to pass into the blood while maintaining the structural integrity of the lung. Chronic exposure to ambient pollutants, specifically PM2.5, nitrogen dioxide, and ozone, disrupts this barrier. Penetrating the alveolar surface, they trigger reactive oxygen species that injure epithelial cells. The barrier breaks down, leaking inflammatory signals into the interstitium. Myofibroblasts activate, depositing excessive, dense collagen fibers. Because the resulting mechanical stiffness further activates these cells, the lung enters a self-perpetuating cycle of inflammation and collagen deposition that the body cannot switch off. At the macro level, this microscopic cycle manifests as physical scarring. This close-up shows the micronodular pattern of lung fibrosis on the pleural surface. Since this process is dominated by the persistence of pathological myofibroblasts, clearing these specific cells from the tissue is the necessary step to stopping the disease. Across the United States, ambient pollution levels have generally declined since 1990 due to stricter air quality regulations. However, the data reveals a contradiction. This chart shows a steady decline in average pollution, tracked in yellow, while the blue line representing ILD incidence climbs. Between 1990 and 2021, the gap between these trends widened, creating a significant epidemiological paradox. This trend is explained by a decades-long latency effect. Fibrosis often develops slowly, manifesting years after the initial environmental insult. Individuals exposed to higher pollution levels in previous decades are only now experiencing symptoms. Cumulative pollutant exposure from the 1970s and 80s is manifesting as fibrotic remodeling in the current patient population. This risk is amplified by an aging demographic. Age-related changes in lung structure and immune function increase the tissue susceptibility to this latent fibrosis. Historical pollution has already initiated the disease process in millions of people. This makes the ability to reverse established structural damage a clinical necessity. Traditional methods of measuring ILD, such as subjective scan interpretation and lung function tests, often lack the sensitivity required to track tissue regeneration in clinical trials. To address this, clinicians have integrated AI textural analysis tools, including CALIPER and SOFIA. These tools provide automated volume quantification of ground glass opacities and honeycombing. This heat map shows how the software mathematically isolates scarred regions to produce a Quantitative Lung Fibrosis, or QLF, score. The QLF score is more sensitive than traditional physiological metrics. A 2% change in QLF volume is a more accurate predictor of mortality than a 10% decline in forced vital capacity. Researchers can now track the physical healing of the lung tissue with an objective mathematical metric. This shift toward early, precise quantification is now a standard clinical recommendation, requiring HRCT evaluation at the very first suspicion of ILD. By establishing an objective way to measure anatomical healing, AI imaging has provided the verification required for regenerative medicine. While imaging allows us to track the disease, the pharmacological pipeline is refining how we stabilize it, moving toward more targeted small molecules. Nerandomilast is a preferential PDE4B inhibitor. By increasing intracellular CAMP levels, it reduces the expression of pro-fibrotic growth factors and inflammatory cytokines. In the Phase 3 Fibroneer ILD trial, the 18 mg dose of nerandomilast significantly slowed the decline of lung function to 86 milliliters, compared to a loss of 152 milliliters in the placebo group. At the same time, researchers developed duperfenidone. By substituting hydrogen with deuterium, they created a compound that resists metabolic breakdown, providing higher drug exposure with 40% fewer gastrointestinal adverse events than standard treatments. Data from the Phase 2b Elevate trial showed an FVC decline of only 21.5 milliliters over 26 weeks, a 91 milliliter difference compared to the placebo. This brings the rate of lung function decline into the same range observed in healthy aging. Localized delivery has also shown significant results. Inhaled treprostinil was evaluated in the TETON-1 trial for its direct effects on the alveolar interface. Bypassing systemic administration resulted in a 130.1 milliliter absolute improvement in lung function over 52 weeks. These advanced small molecules and inhaled therapies represent the cutting edge of disease stabilization. However, they are designed to manage the rate of decline rather than actively clearing existing scar tissue. Beyond small molecules, targeted biologics are being developed to block specific nodes of the pro-fibrotic cascade. The monoclonal antibody BI765423 targets interleukin-11, a master regulator of myofibroblast activity. In preclinical studies, inhibiting this cytokine restored alveolar barrier function and tissue integrity. Managing the systemic inflammatory environment is also a critical component of treatment. Researchers are investigating complementary modalities, including Ayurveda, to address the chronic systemic inflammation that supports the fibrotic niche. This combination of biological node inhibition and systemic management creates the foundation for cellular therapy designed to dismantle the fibrotic niche. Autologous dendritic cell immunotherapy represents the move toward a curative anatomical approach. This abstract highlights the critical role these cells play in interstitial fibrosis. The protocol begins by collecting 50 to 100 milliliters of the patient's peripheral blood to isolate their own dendritic cells. These cells are then cultured and programmed in a laboratory setting over a period of 7 to 14 days. The dendritic cells are loaded with specific fibrotic antigens, teaching them to recognize the protein 8M12 and the transcription factor GLI1. This targeting is highly precise because 8M12 and GLI1 are markers exclusive to scarred lung tissue. They are not present in healthy parenchyma. Once programmed, the personalized vaccine is administered back to the patient through a subcutaneous injection. These cells prime the patient's T cells to migrate to the lungs and selectively destroy the pathological myofibroblasts, leading to a physical reduction in scar tissue. By utilizing the adaptive immune system to hunt specific scar-producing cells, this therapy aims to reset the fibrotic environment without the need for broad immunosuppression. In early clinical and preclinical models, this targeted elimination has reduced lung scar tissue volume by 60 to 80%. Clearing the rigid collagen matrix reduces tissue stiffness, which allows the lung's natural repair mechanisms to restore oxygen exchange. Legacy treatments focus on managing the rate of decline. In contrast, cellular therapy targets the physical clearance of the scar tissue already present in the lung. AI-stratified diagnostics, optimized small molecules, and cellular protocols are now providing clinicians with the tools to address the underlying biological drivers of ILD. The evidence from these emerging protocols suggests that ILD, previously categorized as a terminal diagnosis, is becoming a treatable and reversible pathology. Special thanks to researcher Vijay Simha for the preparation of this research update.